Hi, everyone. Welcome to the Spine Nevada Spine and Musculoskeletal Health Virtual Seminar. This is Molly Canaday, Director of Integrated Marketing for Spine Nevada. We are excited to have all of you join us this evening and grateful to have this opportunity to share recent updates in spine and musculoskeletal healthcare. During tonight's virtual event, you'll hear from two experienced physicians, Dr. Hugh McDermott and Dr. Shane Abdunnur, on the following topics. What is Spine Nevada doing to keep patients safe during the pandemic? Innovative non-surgical treatments to relieve spine and joint conditions. Goals of spine surgery and innovations taking place in spine surgery. Finally, what are hospitals doing to keep patients safe during surgery? We will have time at the end of Dr. McDermott's and Dr. Abdunnour's presentation for question and answer, so please submit your questions through the Q&A box. Without further delay, I'll introduce you to tonight's guest speakers. Dr. Hugh McDermott is a board-certified physical medicine and rehabilitation physician. Before his fellowship training in interventional pain medicine at Emory University, Dr. McDermott fulfilled residency training in physical medicine and rehab, also at Emory University and the University of Loyola. He completed a transitional year of training and education at Presence Health St. Joseph Hospital as a follow-up to medical school at the University of Illinois at Chicago. Dr. McDermott's procedural experience includes interventional spine and musculoskeletal injections, radiofrequency ablations, electrodiagnostic studies, SI joint fusions, vertebral augmentation, and peripheral nerve stimulation. Dr. Shane Abdunnour is a fellowship-trained neurosurgeon with specialty training in spine. He specialized in all aspects of spine surgery, including adult degenerative conditions, spinal cord injury, spine tumors, and deformity correction. He works with the non-surgical providers at Spine Nevada to ensure conservative treatments are exhausted in advance of spine surgery. Dr. Abdunnour serves as the Chief of Neurosurgery at St. Mary's Regional Medical Center. He was the first surgeon in Northern Nevada to perform spine surgery with the assistance of the Globus Excelsius GPS robotic system at St. Mary's. I'll now turn the presentation over to Dr. Hugh McDermott. Welcome, Dr. McDermott, and thank you.
Welcome, everybody. Thank you for joining us this evening. My name is Dr. Hugh McDermott. I am fellowship trained in PM&R and pain medicine from the University of Emory. Just made my way over here from Atlanta last fall. And today I'm going to talk to you about some of the things that we do with PM&R, Physical Medicine and Rehab, as well as some of the COVID safety things that we have been doing for quite a while now around here, but repetition never hurts. And this is a little outline. So we'll start with our COVID safety tips and then get into the PM&R procedures that we are performing here, as well as some of the new things that myself am trying to bring along here, as well as one of my colleagues, Dr. Sue, is performing some of these as well that you may not know about. So first, maybe you've heard of it, but there's this virus that's been going around and we're taking very seriously here in all of our offices, including even our administrative office. And but our first and foremost concern is always going to be for the safety and health of all of our patients and their families. So that's our number one priority, in addition to our staff, of course. We're making everyone wear masks at all times once you're indoors. If you're outdoors hanging outside, you don't have to have a mask on, but once you come inside, we do ask that you put one on. And the intake process has been changed since the last year, which has now less face-to-face contact time for people. We also have a plexiglass between all of our front desk personnel and the people as they're coming in. And then if you can, Part of that process is to check in by phone or hanging out in your car, checking in case there's a wait time or something and you don't want to sit in the waiting room. Totally fine, and we'll check back in with you. Usually our offices have been much more sparse than they used to be in terms of people hanging out. We want to do what makes you comfortable, of course. So where are we doing these telehealth visits? We've been doing these now for a year. They've been going really well. People seem to like it very much, especially our Sparks office and Carson City office. We have people kind of traveling all over for those typically. And now if it's a quick follow-up visit, especially, it's nice to do via the telemedicine. We do a video chat, something like this actually, and we can accomplish most of what we need to accomplish. Not always, but mostly. Again, we talked about the waiting room being, less people in there by having people do some of these telemedicine visits. In addition, this isn't me, but our surgical team, if need be, will perform procedures at outpatient surgery centers where they might have prioritized the inpatient side. You stay in the hospital, but whenever possible now, we try to do everything at the outpatient surgery center, which then you can come home that same day, which then, again, less time in the hospital, less time you're around anybody who might be sick or expose you to something you don't want to be exposed to. I do a few procedures as well, but they're all in the outpatient surgery center. This is the what and how. Like we mentioned before, there's the plexiglass. There's these nice bright pink and gray signs politely requiring or reminding everyone to wear a mask, or if you do feel ill and things like that, to stay home, number one, take care of yourself, and then number two, let us know. And we can always, if you have a same day visit and you really need to see us still, we can always convert it from an in-person visit to telemedicine visit, because again, we're most concerned about your and our safety. And then little stickers on the ground to remind everybody how far 6 feet is. Okay, and then why are we still doing this? As I'm sure you're all well aware, Washoe County statistics are up here. These I pulled from a couple of weeks ago, so it might have changed a little bit, but should be pretty much the same, where there's total cases now are at 42,000. Deaths are 616. So across the country, that's actually not bad, but still it's not nothing. And then in Nevada itself, 285,000 cases, 4,500 deaths. The argument sometimes is, it's a risk, and I take risk every day when I get in my car, which is very true. But when you drive your car, hopefully you're still wearing a seatbelt. Hopefully you're still driving the speed limit, or at least close to it. You wouldn't drive intoxicated. Even though you take all these safety measures, sometimes you still can have an accident. You took all the precautions for a reason, and we're doing the same with respect to coronavirus safety at all of our offices. All right, now that that's out of the way, we're going to get to the bread and butter of the non-operative things. You'll notice that we prioritize here, despite being a minimally invasive surgery facility, all the non-operative things, if we can, at all times, which is also why I'm coming first, I believe. The spine side of what we do for PM&R. First, our spine procedures are done with the guidance of X-ray. Very frequently, someone will come into the office and they'll ask, how are you doing this, or what are you doing it by? And it's this guy here. This is our fluoro screen, and it takes X-rays and can turn up and down, sideways, back and forth, and then these images pop up on our screen over here, which of course always lets me know where I'm going, which is important because I don't think you'd want me doing procedures on you if I didn't know where I was going. We do these for epidurals. Often people ask, is this like when I had my baby? No, it's a little different epidural. That one people do blindly because you have a baby, so they can't use X-ray. And then we don't put a catheter in that just stays in and continually gives you medicine like you would when you were giving birth. So this is a single shot. We get to where we need to be. Very often we're coming in from the side as well, whereas that one, they would have one spot right through the middle that they're using a little different technique to get to. Facets are the joints that sit in the back of the spine. We do injections, blocks, and ablations where we heat up a tiny little nerve that goes to those joints and can be painful, that we stop the signal from being sent by heating it up through an ablation procedure. We also go to the lowest joint in the spine, which is where it meets your pelvis. That's your SI joint. We're going to talk a little bit more about that and some other procedures in a moment. But we also do the basic injections with steroids, blocks, as well as ablations here. And then one of the other features we have available through our PM&R department is induction studies, also known as EMGs. It's a two-part test, but we look at the overall health of your nerves and determine if there's been any damage or anything else that could be found with these studies. In addition to the spine, though, what's kind of lost with us being Spine Nevada is we do much more than that, and that's including musculoskeletal medicine and health. So for these, we can use X-ray or that fluoroscopy again to know where we're going when it comes to our procedures, but we also use ultrasound, which is great for looking at joint space, looking at soft tissue damage and or places to do our procedures via the ultrasound. So again, we're not doing things blindly. Basically joints from your head to your toe, your shoulder, elbows, hips, knees, and ankles. Today I did a couple hips and a shoulder, bread and butter steroid procedures, as well as after you've had EMG study, perhaps it's determined that you've had carpal tunnel. If it's in the mild moderate range, if it's very severe, we can still try it, but not usually as successful. We can do carpal tunnel injections, again, using ultrasound guidance, occipital nerve blocks, particularly if you have headaches, those types of things to the back of your skull, and then just run-of-the-mill soft tissue strains, trigger point injections, that type of thing. And then lastly, I want to highlight some of the orthobiologics that we're doing here. Won't get into the nitty-gritty of them too much. That's not the focus of today's visit, but just wanted to remind people that we do PRP procedures, as well as bone marrow aspirate and fat aspirate, which is the product we use is called lipogyms. And this is Dr. Sue, my colleague over here, demonstrating a lipogym procedure he did a few months back. I believe it was for a knee, but I'm not for sure, so don't quote me on that. It went really well. They did it right here in the office. We numb you up a lot beforehand before pulling that out. These are great. Less steroids, I feel, is always more. If we can avoid them, sometimes it can't be avoided. The one caveat I will add with these is they are cash-based, as opposed to almost all of these will be covered by Medicare or your private insurance. A lot of these are not covered at this time. Maybe that will change in the future, but for now, those are out of pocket. All right, now moving forward to some of the newer kind of exciting things that bringing to the practice, and the one that I've done a fair amount of thus far and has gone well is this SI fusion or fixation is what they want me to call it. Sounds nicer. Either way, same thing. So who is this for? Someone with SI joint pain. Classically, someone, particularly when I see them in this office because of the nature of the practice, doesn't have to be though if you're out in the community. They've had a fusion that goes from their lumbar spine, which is again the lowest part of the spine here, to the sacrum, which is this big broad bone here. And when that happens, the forces have changed that go to the natural curve and forces through the spine. And the next joint that's going to absorb the most amount of force is this guy here, which is the SI joint. And we have two different products that we're using here, both the Omnia PSIF device and the Cornelock device. Both of them work very nicely. They're minimally invasive, which is great. And when you're doing an SI injection, you're doing what's called a posterior approach, or you'll be laying on the belly and we come in from the back. Whereas the previous procedures that came in from the side here, that involved a lot more surgery, a lot more complications came from that. People weren't very satisfied. But now we've changed it. Very little tissue to get through here. It only needs a couple stitches to close it up, and people are doing really well. I do it under general sedation right now. It doesn't have to be, but I find it's just easier to perform with that. And again, it's at an ambulatory surgery center, so you can go home the same day once you've recovered from your anesthesia. Before you could do this, though, there are a couple steps that you need to fulfill. One, hopefully, we've identified that SI joint as your pain source for that low back pain. If it's continued or if it's new, we don't want to be doing this on someone whose pain is not coming from their SI joint, just to state the obvious. Once that's happened, though, we also need to do 2 SI joint injections where you get 50% of pain relief or more. If you don't, that's not a bad thing. It just means this might not be the procedure for you. And again, we only want to do what's best for our patients, which is why we do all these things first. There are a few limitations afterwards. This says 2 weeks. Usually it's 1 for me to avoid driving. They do leave it up to our discretion. We want to keep the incision nice and clean. Usually I'm using staples or sutures that come out at about a week, 10 days. And then this one I also stick to pretty well, but this might be restricted to just 4 weeks to a lifting more than 10 pounds. And then we slowly get you back through physical therapy, which we also have available here up until about that 3-month mark. I've had a few people ask if they can do both at the same time. At this time, I'm just doing one at a time, one side at a time. Make sure you do okay with it, recover well. And then if that goes well and we can avoid the other side, then we have avoided another procedure altogether. All right, moving forward here. Next, vertebral augmentation. Again, something that bringing to the practice we weren't really doing here. In fact, we're sending a lot of these patients out to other local facilities, getting great service with that, but it's something I enjoy doing, and we're going to try and keep in-house a little more here. Vertebral augmentation is a fancy way of saying you've had a fracture to the front of your bone here, also known as your vertebral body. Classically, about 85% of people who have a vertebral body compression fracture have had osteoporosis, and that's why it happened. Maybe you had a ground level fall, meaning you were standing on your feet, then you ended up on your back. Shouldn't really cause you to break anything, but your back's broken. The other reasons for it could be cancer or bad trauma, particularly with a rapid flexion motion. So what do? We come in through the bone here. Again, it's a glorified needle. Again, we do it because it provides significant pain relief. The reason I do it, though, primarily is because there's been a lot of studies out there that have showed, other than a hip replacement, the greatest benefit to people's morbidity and mortality, meaning your ability to get out of bed, your ability to avoid DVTs, which are blood clots to your legs or other places, which could then go to your lungs and cause problems, as well as your ability to keep pneumonia away because you're in so much pain, you're just hanging out in the bed all day. This has been one of the most influential things to get people up and moving quicker, and can actually, I don't say it casually, can actually save lives. So it's one of the things I enjoy doing, because that can make a big difference in someone's life. Again, we do it at a surgery center. You go home the same day. You do use general anesthesia. Do you absolutely have to? No. It just makes people more comfortable. It makes me more comfortable. So when everybody's comfortable, we get good results. So we'd come through this space here. This is the fracture, pardon me. We create this little cavity, which is what's being illustrated with this. It's a balloon that's got a really strong force ability to inflate, creates that cavity in there. And then we fill that with a bone cement to really stabilize that area of the fracture, to then get you the pain relief, which comes from the cement itself, as well as the bones just not moving as much. So that's vertebral augmentation. One of my favorite stories since being here is little Miss Gilly here. She's wonderful. She had a really painful compression fracture, spasms to her back. We did a kyphoplasty. She was coming out of anesthesia. She didn't even want to get off the table. The nurses convinced her to. She was in excruciating pain when she walked in, and couldn't believe how much pain she didn't have after the procedure, and was able to get off the table no problem. The other best part about working here is not only do we treat vertebral compression fractures, we have a few staff members who really like to treat osteoporosis itself. So if I fixed all these fractures, wonderful, you feel better for a second, but then that issue of osteoporosis is still there. And great, now what service have I done if you fracture another one? The answer would probably be none, and I wouldn't do that to my own grandma. So we don't do that to our patients here. We treat the osteoporosis, which then hopefully between the vertebral augmentation or the kyphoplasty combined with your osteoporotic management prevents any future fractures that could have developed had we not done so. She did great. She's come back to see me a few times, still doing great. And I actually did carpal tunnel for her as well, which is doing great. So again, we do all sorts of non-operative things here. Okay, now this is the last one, peripheral nerve stimulation. You've probably heard of a spinal cord stimulator, or know someone who's had one. Similar technology, except for this is out in the periphery, which means basically your joints outside of the spine. If it is in the back, we can treat that as well with this device. So it's a tiny little stimulator here, which, for instance, the example I gave is if perhaps you've had shingles and you've had just chronic nerve pain afterwards that hasn't been well treated, we could put this little stimulator right under the rib where that nerve is that's really irritated. And it doesn't have a battery, which is the best part. It has this external wearable, I just made up a word, external wearable device that can fit. We can do iron-on pockets. We can put it into some clothing, things like that. So only you would know it's there. This is what charges this lead here, which then hopefully is acting at the level of that nerve and giving you pain relief that you couldn't have gotten otherwise. This is great. We can do it with ultrasound guidance or x-ray. Very often we're using both. The main purpose is for pain relief, but if we get functional improvement as well, that's always what we're shooting for. I also mentioned here who inoperable painful joints head to toe. So actually today I had a new consult for this as well, a woman who had 4 surgeries to her knee, multiple knee replacements, knee revision, complications, still having horrible pain. And we're going to look into trying this for her knee pain, and hopefully this goes well. Like a spinal cord stimulator, the peripheral nerve stimulator is a 3-step process where, one, we do a block at the nerve that we've identified that could be causing your pain. Then after you get pain relief with that, we can then move forward with a trial. A trial is where we put this in and it would be hanging out of the skin just a little bit for about 7 to 10 days. You need you to keep it clean so that we don't have any risk for infection or anything like that. Then if the trial goes well, meaning you got some good pain relief, ideally, again, 50% or more, then we can move forward with an implant, which is essentially the exact same thing as what the trial was. We would make one really, really small incision a little further down to then bury this. This gets sutured in so it doesn't move and, get you feeling better and moving forward. Again, this can be done in the office or an ASC, or a surgery center, excuse me. I mentioned that we use ultrasound and fluoro. And then I mentioned this part as well. Got ahead of myself there. So these have been going well. I know my colleague, Dr. Sue, is doing these as well. They're fun to do, and it's a nice option, particularly for those who maybe your shoulder's been operated on half a dozen times and it's still painful. Like I said, the woman I saw today with her knee, optimistic that this will go well for her. But also, if you have some low back pain and you're a really bad surgical candidate, again, we can do these with or without general anesthesia or light sedation even, because we need you to be responsive to us as we're doing it. So when it's in there, we say, is this where your pain is? And if you say no, then we need to move a little closer. If it's too uncomfortable, then we pull it back a little bit further. We don't do anything until we're really happy with our placement. Once we're satisfied with everything, you're satisfied, then we would close up and see how you did. Any questions or anything like that, please put in the Q&A box. We'll address them all in a little Q&A after my colleague, Dr. Shane Abdunnur's excellent presentation that we're about to listen to as well. I'm looking forward to it. Okay, guys, thank you for your time. We'll see each other in the Q&A.
Hi, my name is Dr. Abdunnour. I'm a neurosurgeon at Spine Nevada, Minimally Invasive Spine Institute. Thank you for taking the time to listen to this presentation on some of the advances that are being made in spine surgery. Today I'll be talking to you about updates in spine surgery, what we're doing to keep you safe, and also what you can do to help keep yourself safe and improve your recovery. Just a little bit about me. I was raised in Virginia, went to college and medical school in Richmond, Virginia as well. I did my neurosurgery training and as a fellowship as well in minimally invasive and complex spine surgery in Houston, Texas in the medical center. I moved to Reno, Nevada in 2016 and I've been here ever since. Outside of work, I like to spend time with my family, hiking, biking. I like skiing, and going up to the lake and enjoying all the outdoors that this region has to offer. So just to give you an overview of what I'm going to talk about today, I want to let you in on my philosophy with spine surgery. Talk about the goals of surgery, how you can maximize your recovery and improve the rate of your recovery. We'll talk about what you'll need to do to prepare for your surgery and the things that will help you understand the process. I'll talk about advances in safety that are being made. And then I'll also talk about the first 2 weeks after surgery, what you should expect and what you should be doing, as well as the next month, the time frame from 2 to 6 weeks. These are the most important times after recovery, and it's important if you do the right things, it'll help your process along. So my philosophy with spine surgery is actually pretty simple. The main goal is to help reduce your pain and help you become more functional, essentially to increase your quality of life. And in doing so, I believe it is important to use the least invasive type of procedure to improve your quality of life, get you back to health faster, and also very important to reduce the need for surgery down the road. So what are the goals of any spine surgery? Whether it's the neck or the low back, there are basically two main things that surgery can accomplish. The first is to remove pressure from nerves that have formed, usually due to bone spurs, a herniated disc, overgrown ligaments, or even misalignment of the bones. This can result in nerve pain, back pain, neck pain, or pain down the arms, pain down the legs, the symptoms that you're experiencing. Also, surgery can address any instability or misalignment of the spine, primarily through a fusion. That can also dramatically help with the pain that you're experiencing. There are several things that you can do to maximize your success. I've tried to keep this simple. One of the most important things that you can do before surgery is to stay active. So if you're still able to exercise, enjoy outside activities or hobbies, I want you to continue to do that, even if it's not perfect. If you're using a walker because you're having such a difficult time walking and you just can hardly walk at all, it's important to continue to do that as well. These activities help maintain your core muscles where they are, which will help improve the rate of your recovery afterwards. It'll also help decrease the amount of pain medication that you need, and it'll get you more functional faster. Also, ask about injections. Even if it's just temporary to hold you over until you need surgery. Is that something that could benefit you? Are there other medications that might help? Are there, modifications that we can help you with your job or something like that? So there are many different things that we can do to help you cope with the pain before surgery. When we talk about this, and I say reduce pain medication, number 3, primarily the weeks leading up to surgery, it's really important to decrease the level of pain medicine in your body. This will help pain medication be more effective after surgery, and it will help you get off or reduce the pain medication after surgery as quickly as possible. And the fourth thing is, for those of you who smoke, smokers have a harder time recovering with more chronic pain, and if you can cut that out before surgery and even after surgery, that can help tremendously. I know this is a busy slide, but here are some of the things that you're going to need to do to prepare for your surgery. And it is busy, but our office will help walk you through all these steps and help assist you in anything that you need. So you'll have a preoperative appointment. That generally is in the first week before surgery. We'll go over the details of surgery, like what time to show up. Again, discuss the specific procedure that you're having and the expectations for that. We'll answer any questions that you have about risks or expectations or arrangements that you may need to make for after surgery when you go home. You'll also undergo some preoperative testing. blood work, chest x-ray, EKG, urine analysis. And if you have any other medical problems, like a heart problem or lung problem, or you have any issues with your kidney, we may need to get clearance from another one of your doctors. We'll help arrange all of that. That preoperative testing is generally completed within 1 to 2 weeks before surgery, sometimes up to a month. Also, on the right side of the screen, you'll see some COVID-related testing that needs to be done. And there are precautions that we're taking these days due to the COVID pandemic. You'll need a COVID test 4 days or so prior to surgery, and it's important to quarantine after that COVID test. The reason for all this is that patients that have an active COVID infection have a 20% risk of a major complication. Much of that relates to a respiratory complication because of anesthesia. Regardless, this can happen even with an asymptomatic infection or if you don't know you have COVID, which is why we need to do the test. And I see this continuing to be necessary, these COVID tests before surgery, continuing to be necessary for this foreseeable future. As long as COVID's around, I think we'll incorporate these tests to reduce the risk to you and make surgery as safe as possible. So here are some of the things that we do for safety during your surgery itself. There are x-rays that we take to make sure we get the right level during the surgery, or we get just as high as we need, just as low as we need, and nothing more, nothing else, so that we're not going through extra muscle, which increases pain after surgery. There are robotic spine surgery systems that we're using these days to place screws in the back during a fusion. This dramatically increases the safety of surgery. It reduces the rate of nerve injury, which can be one of the most devastating complications. I've been using a system here in town for over a year, and I haven't had a single problem with it. Patients love it. They really do great, and it helps tremendously. There is also virtual augmentation or virtual reality that helps place screws in minimally invasive fashion with less tissue disruption. All these processes help you recover faster and more completely for surgery. In certain cases, we also monitor the nerves to help increase the safety and reduce the risk of injury to nerves during surgery. There's also surgical microscopes that I use during the most delicate parts of the surgery. Right when I'm working over your nerves, the microscope helps increase the magnification in the light so that I can see exactly what's going on. There's also a drain that may be left in after surgery to reduce the risk of a blood clot over the nerves. There are some things that the hospitals are doing as well, particularly since the COVID pandemic, to increase the safety of your surgery and your hospital stay. So the hospitals and staff separate the COVID patients. The staff that take care of the COVID patients are also separated, so they won't be interacting with you. If you don't have COVID, everything is isolated in the hospital to decrease your risk of contracting COVID while in the hospital. There's also numerous outpatient options for surgery so that you go home the same day or very early the next morning to reduce your stay in the hospital. Don't worry, the hospitals and staff have been dealing with this process for well over a year now, and they have the policies and procedures down to keep you safe. The other thing you can do is have a COVID vaccine and make sure that you yourself are protected, because that will help reduce your risk as well. These are some things that you can do in the first 2 weeks after surgery. Regardless of where you start, you see on the picture on the right, there's a picture of a lady using a cane. So if you're using a cane or a walker, or even if you're out hiking trails prior to surgery, it's important to be active and do what you can after surgery. With that, please understand your activity restrictions. Ask us any questions about restrictions. Generally, there's a lifting restriction, and all this is focused on helping you recover as fast as possible. One of the most important things is to listen to your body and trust your body. If your body says it's not ready to do something, listen to it. If it says you can bend and twist a little bit, go ahead. Just don't overdo it. It's important to walk. That helps you get your energy back, decrease pain so you can get off the pain medicine sooner. It helps build your cardiovascular fitness again and increase your core muscle strength. It'll put you in the best position as possible to start physical therapy. Also, I want you to decrease or stop the pain medication depending on the surgery and depending on what you are on medication-wise before surgery. With many outpatient surgeries, it is possible to be off all pain medication within a few days or a few weeks of surgery. It's also important to make sure you have your first postoperative physical therapy appointment set up sometime between 2 and 3 weeks after surgery. There are some other things that you can do between the 2-week and 6-week period. The most important thing that you can do, honestly, is to work with physical therapy. Listen to what your therapist tells you because everybody's at a different spot. The physical therapist will work with you to customize a plan to help increase your range of motion, decrease pain and soreness and stiffness after surgery, and get you back to the most active lifestyle that you can be at. So listen to them, they will work with you. They've been doing this a long time. Between 2 and 6 weeks, you really should be transitioning to anti-inflammatories or NSAIDs instead of pain medication. This will help increase your endurance, decrease your fatigue, and help you recover faster. The last point I think is the most important, and of course is a bit of a double-edged sword. You need to push yourself, but you also need to be patient. It's important to understand that a lot of times recovery is 2 steps forward, 1 step back. So understand that. Don't let little bumps in the road throw you off your plan and where you're headed. Also, as you understand your expectations and you understand where you should be from us and from your physical therapist, it will help you see if there are any major problems or issues that you should be concerned about and should be asking us about. So in summary, we've gone over a lot, but just to keep it simple and the main ideas. Discuss your goals and expectations that you have for yourself with your surgeon or your provider. Understand the recovery process and where you kind of should be within the first 2 weeks and then within the first 6 weeks. That will also help you gauge your progress and keep your motivation up. One of the most important things is to stay active, both before surgery and after surgery. Obviously, you'll have limitations, but the more you can do, the faster you'll recover. Reduce that pain medication, get on anti-inflammatories. That will help, again, keep your energy level up, decrease the fatigue, and get that stuff out of your system. The last point, ask questions. Before surgery, after surgery, if you have any concerns, let us know. If you feel like anything is wrong, let us know. We can help address any of these issues at any point. Thanks again for taking the time, and I'm happy to answer any questions that you may have.
Thank you for all the questions this evening, and thank you for attending our virtual event tonight. To recap tonight's virtual event, Dr. McDermott shared about non-surgical treatments for spine and joint conditions. He also helped inform what the Spine Nevada practice is doing to help keep patients safe throughout the pandemic. Dr. Abdunnour discussed the goals of spine surgery and innovations taking place in spine surgery. He also highlighted the safety protocols in place at local hospitals to help keep patients safe. Thank you all for joining. To learn more or to request an appointment, please give us a call at 775-348-8800 or visit spinenevada.com and complete the appointment request form. Thank you again. Stay safe and healthy. Good evening, everyone.